Thanks so much, Mary. Para 50. Sige, 17.
But now I have a, I don't know if they loaded my PowerPoint.
They need your computer.
My jet lag.
Good afternoon, everyone, and welcome. I really am at a loss for words to adequately express how happy we are that you all have, made the time to come here today. I mean, I see familiar faces. Thank you for being with us again today, and I also see new faces, and we're hoping to meet new friends. When I was preparing for this to talk, it was kind of difficult and challenging because there's just so much that I wanted to say and wanted to share with you. And as I was thinking through these things, I realized that it really just boils down to one reason why we are here, and it's because things can be better. We can respond to the growing issues related to drugs and drug use in a way where each and every one of us lives a life of dignity as we deserve. Each one of us is able to unleash our fullest human potential. In anything we do, we cannot make human sacrifices. There's so much that we can do, even as soon as we leave this hall, that can help make people's lives be better. Things that are scientifically demonstrable, things that are grounded in human compassion and a sound understanding of human behavior. We are all social beings. We need to recognize that each one of us thrive on being with people and on the relationships that we have. So today is not just about learning a new approach or about doing something different. We are here today because this is about making room in our hearts for when a person comes to us for a question or for help. They are a person first and foremost. As journalist Johan Hari put it, the opposite of addiction is connection. We thrive on human connection. If we do not make that connection with our fellow human being and make the effort to understand what is truly going on, then we can build all the rehabs and fill every barangay with rehabs. But then what for? It is not about building structures. It is about creating safe spaces. Any sort of space where people are encouraged to go to, space where people can open up, be vulnerable, and do what is arguably one of the hardest things any one of us can do, and that is to ask for help. So yes, that is why we are here today. The first contact each one of us have with a person seeking information or seeking help can largely influence the direction one's life takes. Today, the available choices for a person who is using drugs are either to be locked up in rehab or locked up in jail. So how is it surprising that people prefer neither? Placing people who use drugs in jail benefits no one. Not the person involved, not society, when scarce resources are spent on band-aid solutions that deter us from truly seeking out the real problems and their real causes. Putting people in jail only leads to the loss of substantial human potential. Chasing the wrong problems with band-aid solutions is never going to solve anything. Harm reduction opens us up to a wide range of options that are supported by science and unencumbered by dogma. We have a reported 1.3 million people who use drugs, with only 3,266 reported to have entered rehabs. That is a dismal 0.25%. Article 2, Section 11 of our Philippine Constitution tells us that the state values the dignity of every human person. Article 2, Section 15 states that the state must protect the fundamental right to health that each one of us have. So if we are only reaching 0.25% of the 1.3 million, what is happening to the 1,296,734? The question now that is placed on our collective shoulders is, what are we offering our 99.75%? So our guest today here is Dr. Andrew Tatarskiy. I had known him since 1997, so that's 18 years ago. As I met him as I myself was struggling to understand what this drug thing was all about. And he was most generous, even if he met me for the first time, he was most generous with his time and his brilliance. And he has had tremendous influence on me. Dr. Tatarskiy has developed integrative harm reduction psychotherapy for helping people with substance use concerns and other risky behaviors. IHRP brings psychoanalysis, cognitive behavioral therapy, and mindfulness together in a harm reduction frame. The therapy has been described in his book, which is here, Harm Reduction Psychotherapy, a New Treatment for Drug and Alcohol Problems, as well as on the series of papers. The book has been translated into Polish and Spanish. Andrew holds a doctorate in clinical psychology from the City University of New York. He is founder and director of the Center for Optimal Living in New York, a treatment and training center that is based in integrative harm reduction psychotherapy. He is also the founding member and past president of the Division on Addiction of New York State Psychological Association and a member of the board of Moderation Management Network, Incorporated. And he is also the clinical advisor to the New York State Office of Alcoholism and Substance Abuse Services. He is a professor of professional practice, the Harm Reduction Psychotherapy Certificate Program in the New School of Social Research, and a consultant in the advanced specialization in family and couples therapy at the postdoctoral program in psychotherapy and psychoanalysis at the New York University. Dr. Tatarskiy trains nationally, internationally, and we're so grateful that he is with us here today. So before I give the floor to Dr. Tatarskiy, I just wanted to let you know that this is an open dialogue. This is our format, and we really encourage everyone to participate and ask questions as much as possible. I think that is how we will continually instruct ourselves when we participate. We also consider this like one of those safe spaces that we talked about, safe space to ask any question that's in your minds and in your hearts. We also have, as I think Grace mentioned earlier, there are cards there if you want to have questions. We have our team here who will be assisting you if you need help. Where are they? Grace, so that you know them. Grace, Mikli, Patrick, Mon, Phil, RM, and of course myself. So just raise your hands and they'll be happy to help you. So feel free also to write or text your questions. We have on the tables the hashtag and all of that, and your paper and pens. So anyway, you didn't come here to listen to me. So without further ado, please help me welcome Dr. Andrew Tatarskiy.
So I am tremendously honored and excited to be here, to have an opportunity to exchange ideas with you. I'm going to share with you ideas and practices that I have been collecting over 35 years of practice primarily as a psychotherapist, as a psychologist working in addictions. I've been working in the trenches and really just trying to figure out how I can be more helpful to my patients. And in the course of that practice, I've developed, gathered together a bunch of ideas that ultimately brought me to what I think is a radical statement, which I'm going to make, and I really invite you to consider this as we go through the afternoon, which is that I believe that a harm reduction framework, particularly an integrative harm reduction psychotherapy, substance use treatment approach, is an essential part of effective treatment, and that it can really expand and extend the reach of the treatments that we're already engaging in, and help us as a field to be more effective at helping people with problematic substance use. I want to really thank Inez for inviting me. It's really always a wonderful opportunity for me to exchange ideas with colleagues who are engaged in the same work and are committed to the same mission, which is how can we be more effective and more helpful to more people that are struggling? And that's really the overarching question that we're here to discuss together. So let me get into my material. I think that the addiction, that addiction treatment is in crisis globally. You know, you heard from Inez the limited effectiveness of treatment here in the Philippines, but numbers like that are echoed all around the world. This is Dr. Ed Cancian, a Harvard psychiatrist, said, we don't need to look hard to see that we're losing the battle against addiction. In the United States, we have over 100 people a day that are dying from opiate overdose. We have an epidemic of overdose. We are not helping the majority of people with substance use problems globally, and traditional abstinence-only approaches are really limited in their appeal and their effectiveness. That's a proposition, and I think it's really important at the outset for us to distinguish between harm reduction approaches and abstinence only. We're not talking about abstinence-based treatment, because from my point of view, the harm reduction framework, as I will flesh out this afternoon, is a framework that is an umbrella concept that embraces abstinence-based treatment for those patients that it's appropriate for. So the abstinence-only treatments, which really dominate our field globally, are treatments that only accept patients that are willing, able, and ready to embrace abstinence. And so I think that those treatments can be extremely helpful to some people, but they are very limited in their effectiveness. And the proposition that I'm going to share today is that harm reduction can really extend that reach, including abstinence-based treatments, but offers a whole range of different options that we will go through today. So I'm going to just very, very simply and quickly give you some basic definitions of harm reduction, but then I'm going to kind of go far afield, and I'm going to take you through what I consider to be the rationale for harm reduction, the limitations of traditional treatment, the challenges that people with substance use issues present to us as a field, and a new model for understanding the complexity of substance use. So we're working with a model shift, which I'm thinking of as really a scientific revolution that's happening in the field right now, from old ways of understanding problematic substance use to a new emerging psychobiosocial model, a much more complex and nuanced model that I think helps us to understand, better understand, that large group of people that are not ready, able, or willing to embrace abstinence-based treatment, and who we have been very ineffective at reaching. But so very simply, what is harm reduction? This I think sums it up in a way. I don't promote drug use. I don't promote car accidents either, but I still think seat belts are a good idea. The essential idea is that risk is a part of life. We all, risk is something that we can't escape, being humans and being alive. But we engage in harm reduction practices all the time when we wear seatbelts, when we wear bicycle helmets, when we learn about risk and how to reduce risk around diet and so on and so forth. So harm reduction is part of our life in an everyday sense. One of the first early American harm reductionists called it an attitude. It's sort of a way of being with people. Lynn Paltrow says harm reduction is enabling health, not punishment and stigma. And I would say that it's a framework for reducing harm and promoting health, growth, and positive change without requiring abstinence. For me, that's the essential harm reduction shift. That we don't require abstinence as a prerequisite to beginning a treatment process. And that, for me, opens up unimaginable possibilities for how we can be more helpful. This is the Harm Reduction Coalition's definition. This is the American home for harm reduction. And they say that it is a philosophy and a set of strategies. Now, this is what I think is a really essential idea to get. Most people think about harm reduction as what I consider public health harm reduction, syringe exchange, opiate substitution treatment, and so on. But I think of it first and foremost as a philosophy or a set of principles, guiding principles. And that then there are a wide variety of strategies that are derived from those principles. So they say harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Going down here, it incorporates a spectrum of strategies from safer use, managed use, to abstinence to meet drug users where they're at, addressing the conditions of use along with the use itself. So it sees drug use in a complex matrix, the conditions of use as well as the use itself. So it's a very interesting philosophy for me. Now, having talked about the crisis that we're in globally, I think that harm reduction heralds really, really good news. I think that integrative harm reduction strategies are appealing and effective to many people that have not been helped. What I have found is that many people that are not motivated for traditional treatment become motivated when they hear about the harm reduction framework. And I will give you some clinical examples as we go along. So that it's interesting to think about the unmotivated patient is not necessarily unmotivated for help, but maybe unmotivated for what's available. And that if we make more options available, people then become motivated. We can also consider that integrative harm reduction therapy enhances the delivery of existing treatments. So we have a whole range of different treatments in our bag of tricks. And what I'm going to suggest is that if we add an integrative harm reduction component to existing treatments, that will enhance their effectiveness. So we're not talking about dismantling the treatment system. We're talking about bringing something to it that will make it more effective. I wrote a paper in 2003 titled Harm Reduction Therapy, Extending the Reach of Traditional Treatment. So how can we extend that reach and then enhance overall success? So this is the outline for today. We're going to talk about some real-world challenges of helping people with substance use problems. What are the problems that they present us with? What are the challenges? I'd like us all to be thinking about that. And all of you who are working with substance users in one context or another face these challenges every day. What are the toughest challenges is what I like to invite us to think about. Then we'll touch on the limitations of traditional abstinence-only treatment and the case for harm reduction. Then I'll get into this model shift idea. Models are ways of thinking about a phenomenon, sort of shape how we see it, how we view it, and how we act on it. So I want us to think about all of the complicated models for understanding addiction and substance misuse that are floating around, And how do we make sense of all of that complexity to create a model, a meta model sort of, that can kind of encompass that complexity. Then we'll get into, so that may be the first two sections of today. We're going to break the day into 4 sections, after which we'll have discussion and exchange. And then we'll dive into harm reduction in more depth. I want to talk in detail about the principles of harm reduction, the implications of those principles, and then go through a wide range of interventions that have been developed for parents, for children, for college students, for people who need psychotherapy and substance use treatment, self-help options. There's a world of harm reduction out there that's very, very exciting. And throughout the day, I'll share with you some clinical vignettes of patients, real patients that I'm working with. I'll also share with you comments that I've solicited from a number of my colleagues, some of my patients, some people that I'm training in a program in New York, so that you'll get not just my voice, but we'll hear a number of different people's voices who are working in harm reduction. And then I'm going to get into the harm reduction psychotherapy in a kind of a summary fashion, mapping out 7 therapeutic tasks. And for those of you that are clinicians that will be joining us in our next 2 days, we'll be going into the therapeutic process in a lot more depth. And I think we still have some openings. So if there are people here who haven't signed up yet and you become excited about this material, I would welcome you to join us over the next 2 days. So first I wanted to share with you briefly my journey to this point. How did I get to the point where I believe what I believe? And in a way, my professional history kind of mirrors the work that I'll be sharing with you today. I got my first job out of my training as a clinical psychologist in 1982 at an addiction treatment center up in East Harlem, a very poor neighborhood in New York City. And they were doing, this was a multi-modality addiction treatment center. They offered a number of different medications and individual and group treatment. And I learned the traditional abstinence-based treatment approach in that clinic. At that time, in 1982, that was the only model. Today, it's mostly the only model. But there's this model that really came to dominate the world, a disease concept, abstinence-only approach, which I learned. For the first 8 years of my career, I worked within that model, and I wound up running a couple of programs as clinical director. And we certainly helped many people. So I have a deep love for my first introduction to this work. But I began to see over the course of those first 8 years that we were not helping the majority of people that were coming to our programs. The majority of folks that came for intake didn't get into treatment. Many of the people that were in treatment didn't stop using drugs. And in many cases, we had to discharge them because abstinence-only treatment, needs people to get with the program, so to speak. Or they either need to leave the program or go to a higher level of care. There was a number of experiences that I had that were increasingly troubling to me, and I'll give you one example. There was a young man who came to treatment, a man in his late 20s, who came for a cocaine problem. And week after week after week, he continued to use cocaine. And one day, I recall sort of confronting him in group. We can't keep you in treatment if you continue to use cocaine. And he said, I'm really troubled by my cocaine use, but I cannot see myself stopping. And I said, why not? And he said, I have HIV, and in the mid-'80s, or the late '80s, HIV was a death sentence. I'm so anxious and I'm so depressed, I have a hard time getting out of bed in the morning and going to work. So I need the cocaine to help me with the depression and help me get going. So as a clinician and a therapist, I could empathize with him, and it made sense to me why he couldn't stop using cocaine. On the other hand, as an abstinence-only clinician, I couldn't keep him in treatment. So this is the kind of conflict that I was faced, and I bet you many of you folks have faced, which is that our model doesn't really, offer us much to say to patients like this. And the accumulation of cases like that made me increasingly sick. To have to discharge a patient for drug use who's coming to treatment for help for drug use made no sense to me. So as it happened, I started a private practice around that time, my own independent practice. And I began getting referrals of patients that were actively using drugs and wanted help. And they seemed to be good candidates. So I thought, although it was blasphemy at the time, that I would experiment with working with active drug users. And lo and behold, what I found is that many of them did incredibly well. They engaged in treatment. They addressed their drug use and other issues. Some of them cut back. Some of them stopped. And so here was a quandary for me. The overarching theory and treatment model wasn't working so well in our treatment programs, and working with active drug users, which is not supposed to be possible because they're not supposed to be available for therapy, was actually working. In 1994, I had a conversation with one of the godfathers in our field, who unfortunately passed away a few years ago, Dr. Alan Marlatt, one of the authors of relapse prevention. And I told him my quandary, and he said to me, "You're doing harm reduction." So that introduction to a harm reduction model that is a different way of conceptualizing how to help presented me with a vision for how therapy and substance use treatment might look very different and be more effective. So the last 21 years I've spent really trying to flesh out the implications of the harm reduction model, and that's really what you're going to hear today. So let me share with you a couple of other typical patients, like the patient I just mentioned. This is Valerie. She came to me about 4 years ago. She came to me as a high-powered super mom. She was the president of the PTA. She was helping with the fall festival. She was really a super mom with 2 young children, getting them out to school, a really good mother. And she came to me, and in the first session, she said that she was injecting Dilaudid, a powerful prescription opiate that is very similar to heroin, 4 to 5 times a day. And she told me that she had been doing this for the prior 2 years. And then she said, "You're the only person I have told, and the only reason I came to you was because I knew that you wouldn't ask me to stop." She was very conflicted about her use because primarily she was afraid that if she was discovered, she could jeopardize the custody of her children. And she was also very disturbed because she felt that she was dependent on this drug. She needed it. It was dominating, her life. On the other hand, she was very, very conflicted. She said she loved using it, and she couldn't imagine stopping. As we got into the therapy, I did a harm reduction risk assessment, which is something that, is an essential part of this work, assessing whether, in fact, a patient is using in a way that's safe enough for us to undertake the work with an active user. And that's something we can talk a lot more about later, if you like. But I felt confident that she was using with safe injecting practices, knew what she was doing, and I undertook the therapy with her. As we got into the work, what very quickly emerged was a history of trauma. multiple traumas. And this emerged around our exploration of her drug use. Trauma is often embedded in the impulse to use a drug, which is something we'll go into in more depth. Thinking about the drug use as meaningful, not just as a reaction to the drug. So she was sexually, or rather physically abused by her father. She was raped at the age of 19. She was sexually abused by a relative, a stepbrother, and all of this contributed to drug use at a young age, in her early 20s, which she stopped when she went to drug treatment at Daytop Village. However, the underlying issues weren't addressed, and at a later point in her life, in her 30s, she had a terrible back problem, went to a physician who prescribed an opiate, and the drug use kind of took off again. And so this was the picture that she presented. Fast forward, and I'll share more about it later on, when we really dealt with the trauma over 18 months, she became ready and able to detox. She went to a detox voluntarily. She got off the Dilaudid. She got on a very low dose of Suboxone, which she has been stable on now for a year and a half. And she's now contemplating detoxing from the Suboxone with really no other problematic substance use at all. So this is one example. We can talk more about it at the break if you like. This is another kind of picture. 20-year-old young man. When he came to me, he was engaged in massive and frightening polydrug abuse as a college student, using all sorts of things. Some people call this a garbage head. I mean, but he had a life-threatening illness which took him out of school, and after recovering in the hospital and being out of school, he began using drugs. And it was clearly a reaction to the trauma of his illness and of being dislocated from school. We worked together for about 9 months while he was actively using. He was not interested in stopping. And we worked through a number of these issues, and he became ready and able and interested in going to detox and rehab, which he went to. When he came through the detox and rehab, they put him in an intensive outpatient program, and he said, "I'm ready to stop all the drugs, but not cannabis, not marijuana." And they said, "Sorry, we can't take you." This is another way in which abstinence-only treatment works. So he didn't go to intensive outpatient, he came to intensive Tatarsky, and he was able to maintain his abstinence from the problematic drugs and make tremendous progress. He occasionally uses alcohol and marijuana, but his life has become stabilized, and now he's off to graduate school. So he's done amazingly well. We can talk more about that case as well later if people want to. So the active drug user that doesn't want to stop, and the drug user that will stop many things but not all things, are typical kinds of patients that come to us. Now, I would argue that these patients are typical of the majority of drug users. The majority of drug users, when they become concerned about their use, they may not be completely out of control yet, but they're starting to be troubled by problematic drug use. At that point, the majority of these patients are not ready, willing, or able to stop. So what do we do with them? That's the question. Do we just let them continue using so that the use escalates and they hit a lower bottom, which we hope will be motivating, but in many cases is lethal? So is there a way that we can intervene with these kinds of folks while they are still using, around their conflict about stopping? Now, I am not such a statistics person, but these statistics really are hair-raising, and they're actually somewhat similar to the ones that Inez shared with us. The majority of problem users in the United States are not being treated. This is an annual household survey that's done, survey on drug use and health by the United States government. So these are government statistics. They estimate that around 60 million Americans binge on alcohol, 5 or more drinks at a sitting. Binging is not the same as abuse or dependence, but one binge can kill you. So this is significant, frightening alcohol use. And 16.5 million binge on alcohol at least 5 times a month. So this is a tremendous number of people. These are just called heavy drinkers. Then when we move to abuse and dependence, there's an estimate of close to 23 million Americans that are severely involved with substances. To me, this is mind-boggling. We're talking about 95 million Americans are engaged in problematic substance use. Only 2.5 million of them are in treatment. So Inez asked the question about what about the other 1.2 million in the Philippines? And I'm wondering, what about the other 93 million Americans? Now, clearly, a lot of these folks don't need treatment. We do know that a lot of people age out. There is such a thing as natural recovery. But this is your numbers. 1.3 million are dependent on drugs, and only 3.266 are in treatment. Most problem users don't want abstinence, and they avoid treatment. Like the second fellow that I mentioned, many people do want to stop some problematic substance use, but not other substances. So they have different goals with different substances. The traditional abstinence-only approach says that you've got to be completely and totally abstinent from all mood-altering substances. So like my patient, many of these people would be excluded from treatment. Now, these are the last statistics I want to share, but I think these are really, really telling, and I would really wonder if anyone here has comparable statistics, if you've collected them in the Philippines. Just stay with me. So between 2010 and 2013 combined, the government looked at a large number of Americans, and they found the folks that needed treatment, and those people perceived a need for treatment, but they didn't seek it. And the question was, why not? The first number, 40%, said because they did not want to stop. They needed treatment. They thought they needed treatment, but they didn't seek it because they didn't want to stop. Now, the next number was no health coverage. They couldn't afford it. The concern about a negative effect on the job, the concern that going to treatment might cause neighbors in the community to have a negative opinion of them, not knowing where to go to treatment, so on. And one other number, and then we'll think about the implications. This is the people who needed treatment, perceived treatment, and they sought it out, but they didn't get it. Similar, although it's a little reversed, the first number is 37% didn't have the health coverage, and 24.5% didn't want to stop. So you see there's a trend here. Now, this is what I conclude, and this is what I think are 3 of the things that we as a society need to really take on. If our abstinence-only system only offers abstinence as a goal and as a treatment, and there's a significant number of people that need treatment and want it but don't want to stop, there's a disconnect. We're not offering relevant treatment that will be appealing to those people. It doesn't meet them where they're at. And secondly, I think, and this is a terrible thing, in the United States, we have this terribly huge substance use problem, and we are not providing quality, affordable care for this large group of Americans who need it. So for me, that's got to be part of drug policy reform and treatment reform, to take all of those dollars that we're putting into interdiction and criminal justice approaches and make more quality of treatment affordable. You know, some of you, I'm sure, know the numbers a lot better than me, but if we provide good quality, affordable care to everyone that needs it, everyone benefits, both from a humanistic standpoint, a health standpoint, a moral standpoint, and a financial standpoint. And finally, stigma. Some of those folks talk about being worried about their job and worried about what the neighbors will say. That's stigma. Stigma kills. If we don't take on as a society the stigma that lives within, is endemic in our society, that prevents people from seeking out help, I think we contribute to escalations in drug use and overdose. So this is our project. But today we're going to be focusing more on the treatment side than the social policy side. Then finally, I couldn't help myself, but of those 95.5% of those that needed treatment but didn't perceive the need, is it possible that many of them also didn't perceive the need for the same reasons that the other ones gave, which is that the treatment system wasn't appealing to them? And I can honestly tell you that as we've put out in my Center for Optimal Living, we put out, our banner is that we offer harm reduction therapy. That is, we will see active drug users wherever they're ready to begin the work. And we have people finding us on the internet seeking out therapy who were not motivated for treatment before they heard about this approach. So it's like shifting the frame, shifting the way that we frame treatment to appeal to folks, to really be relevant to people's needs, changes motivation. So that's a key idea. Finally, with statistics, there are a couple of studies in the United States, one 93% and one 75%, found that those numbers of treatment programs, specialty treatment programs, only offer abstinence as a goal. So most treatment is not relevant to most of the using population. And studies show very low rates of retention. So this is kind of dismal. And I think that frequently, all too frequently, people attribute it to the addict. The addict isn't motivated. The addicted person is self-destructive. The addicted person doesn't care about themselves. I think we've got to, be curious about that, and I think we have many reasons to think otherwise. One of them is syringe access, which I'll get to. When we offer people appropriate treatment, they tend to seek it out. So let's think about how treatment is limiting, society is not sufficiently supporting good treatment, and stigma, that is, negative perceptions, negative assumptions, negative reactions to people who have, used drugs or have problematic relationships to drugs are really problems that can prevent people from seeking help. How can we make a difference? Now, the other thing, and this is an interesting thing to consider, how harm reduction therapy is really relevant to other kinds of problematic, risky, and addictive behavior that people can't realistically think about abstaining from, like sex, like eating, like scuba diving, like backcountry skiing. I mean, these are things I would never do, climbing, high mountains, but things that are tremendously risky that we do all the time. And now, increasingly with internet porn, and even we've been talking in our center about cell phone addiction. That is, that people are so addicted to their cell phones, they're interfering with human interaction, human contact. So, thoughts on clinical challenges. I've said a lot, getting a little hoarse here, but I'd like to check in with the group now. What are your questions? What are your comments? What are your personal experiences? Are they, I'm here really to offer my personal experiences for you to sort of consider in light of the context in the Philippines, which I think is similar in many ways, but no doubt very different. And the question is, how might these ideas be relevant to your situation? How do you see the challenges in your settings? Maybe we can hear a little bit from you folks. And how have you understood the limitations? Have you come up against them yourself? How have you understood that? What changes do you think might improve the situation? So maybe we can take 10 or 15 minutes to hear from the group, to dialogue. There's a mic. Actually, here's another mic if you want to.
Anybody would like to be in queue?
Yes.
Very nice presentation, and we're really intrigued with the concept. You know that we're schooled as far as abstinence-based programs are concerned, and that's our programs here also in the Philippines. We do abstinence-based programs. Now, the only problem I see with a similar implementation would be our law. In the Philippines, I think we have mandated, our legislators have mandated how we should treat our patients. No? And it's really limited to abstinence-based programs and institution-based treatment programs. I don't know if you have experienced the same problems in the US. Do you have limitations as far as your laws are concerned in implementing these kinds of treatment?
Well, I mean, this is a very interesting question because, of course, we have limitations. When syringe exchange or syringe access came on the scene in the mid to late 80s, the syringe exchange community was underground activists and were breaking the laws. Yeah. And so the activists and the accumulation of evidence, using both empirical evidence and clinical experience, put pressure on local communities, and in many local communities that was changed. We still have a federal government which has a ban on funding for syringe access. So the United States is a very interesting place because, in some jurisdictions, laws have been changed. I've been very interested in the idea that we as clinicians, we as people that are working with patients, and we know what works and what doesn't, have a moral obligation to stand up and become agents of political change. Because all too often, politicians are weighing in on medical and treatment decisions that they have no business weighing in on. So, I mean, an overarching theme here is drug use should be treated as a health issue, not a criminal justice issue. And I'm not talking about crime that is committed by drug users. Of course, crime should be prosecuted. But the use of drugs as, nonviolent drug use that isn't hurting anyone else, I think, should be seen as a health issue. But there's another interesting story that I just heard, a powerful story. In Switzerland, I recently was at a conference put on by the Swiss Society of Addiction Medicine. Robert Hemmick is the director, and he invited me and a bunch of others there to present. He told me the story that back in the late 80s, syringe exchange and other harm reduction methods were illegal. And a group of doctors decided to get together and pitch a tent where the drug users, congregated, and set up tables. And when the government came down and said, what are you doing? You're breaking the laws. They said, well, we should talk about those laws. And they encouraged the government to change the laws. So I see, I mean, my way of approaching this is that our government and us as clinicians, we are one community. We share the same interests in figuring out how to be helpful to people. And rather than thinking about fighting, I like to think about encouraging dialogue and, seeing how we can come together to make the changes that are needed.
We have another question.
Hi, Doctor. It started with really liking how you described harm reduction by extending or probably encompassing beyond these limitations that we have right now. There's a couple of, I think, challenges that we face or we are in our practice that we face. One example is a client that I've been seeing for the past 2 years. This person has a morphine addiction. Now, one of the challenges was, the alternative. One of the alternatives that we were looking at to replace morphine is OxyContin, which is far, far, far more expensive than morphine. So we would get him to some point of being stabilized or probably lowering that harm from morphine, but he would revert back to something that's probably cheaper. Another one is what you mentioned about stigma. At one point during this 2-year course, the family was at one point wanted to keep him in the hospital and didn't want to get him out from detox unless he was off everything, and had to fight with I'd probably use that word, lack of a better word, but had to long discussion with the family that we couldn't work on that model. That one way or another, for him to get engaged in treatment was to more or less explore the idea of getting into something. He's a very high-functioning individual. Started addiction later in life because of an accident. And then another one is this is kind of, but it's real. Somebody probably starting with marijuana, exposed to how we are in our setting right now, would start with marijuana and then ending up with something of a probably more harmful addiction, like meth. So that's one challenge. As we try to practice this, more or less as you were describing it, we kind of just labeled it already what we've been doing as harm reduction. We found that really the abstinence-based model was very limiting, together with probably what Dr. Benji has already described with the law. So we're looking at stigma, we're actually looking at actual practice in the trenches as you speak, and this is a multiple of addiction, not only with, predominantly in the Philippines, it's meth, but we've been looking at clients throughout these years, morphine, heroin, and all of these things. So anyway, thank you. That's my penny cents for this one.
Thank you. Was that a memory test? I probably failed, but I think I understand that you don't have opiate substitution treatment here in Philippines. Is that right? Suboxone. Yeah, I mean, this is a serious problem because methadone treatment in study after study after study is highly correlated with helping people stay alive. And in some cases where methadone has been withdrawn and people had to return to heroin, you have a huge rate of overdose and death. On the other hand, I think that methadone can be a very interesting and flexible treatment. It doesn't have to be maintenance for life. There are people I've worked with who maintain, stabilize, and then detox and do very well. But similarly with Suboxone, and actually in Switzerland, they've done studies that some patients do extremely well on morphine maintenance, particularly patients with psychiatric issues, that the morphine tends to treat symptoms of schizophrenia and bipolar. So that ideally we should have a full range of opiate substitution treatments we can offer that we can work, individually tailor and in a collaborative way with each patient. But so that's a fight that you folks have to have. In terms of the family, I think if we're shifting our model for how to work with the individual, we need to give the family as much education and support as the identified patient, the drug user. We're doing this in my center right now. We're seeking a family person because, a model shift, that model lives inside of all of us. We all grew up with that particular model, and we need to re-educate the patients, the families, and ourselves to get the families on board to support the treatment with the primary patient. Or else they're going to subvert it. They're going to panic. They're going to think, you don't know what you're doing, and they're going to take the patient out of treatment. So families need as much help as the drug-using patient. There was one more issue. Oh, medical marijuana. It's interesting. We'll be talking in the next section about models and about complexity and about understanding drug use as a highly unique relationship that each person has. So I don't think that I think there's a lot of controversy about whether marijuana is really a gateway drug. It may be for some people, but it seems to me that question needs to be examined in a highly individual assessment with each person. The overwhelming majority of people experiment with marijuana and don't become regular users and certainly don't become dependent. So why those particular individuals experiment with marijuana and then go on to develop problems, I think, and I'd love to hear what everybody else thinks as well, has to do with a complex mix between the drug effect, the social context, the personal psychology, the family context. So we'll wade into that. That's a good question to kind of get us into that next topic. Maybe one more?
One more.
Do you have a comment, Inez?
If you could, no, you could introduce them.
Okay. Hi, good afternoon. My name is Mara. I work for Action for Health Initiatives. I do HIV work. I have two things I was reflecting on as you were presenting when you were talking about challenges that we have in the country. One is, I think one of our biggest problem in the Philippines is that people who think they know the solution to drug use are people who have actually not experienced it. And there hasn't been any effort to actually reach out to the communities and talk to them about their issues so we know how to help them. I think that's a big problem in a lot of approaches that we have in relation to drug use, in relation to a lot of problems that we have in the Philippines, in fact. And I like the idea that when you were sharing your learning on harm reduction, you were getting it from actual stories of real people. And I think that's what we need to have that space to actually allow the communities to talk about their issues so we know how to help them. The other challenge that I'm looking at is in relation to my work in HIV and AIDS. Because drug use, particularly people who inject drugs, are also highly vulnerable to HIV and hepatitis C. And we're already seeing the impact of that in the country, and still our hands are tied. We cannot fully implement a harm reduction program in the country because of the laws that we have that limit the kind of programs we have for people who use drugs. So essentially what we're doing is letting people die from drug use as well as from HIV and hepatitis C.
Can you share with me, as a newcomer, what those laws are that you're referring to?
Okay, we have our Dangerous Drugs Law Act, Dangerous Drugs Act, which essentially criminalizes drug use and also criminalizes distribution of drug-related paraphernalia, including syringes, which is an essential element of a harm reduction program in the prevention of HIV and AIDS and hepatitis C, for example.
And just for the record, syringe access has been one of the most successful public health interventions, period, in history. In communities like Australia, where syringes, clean syringes were made available at the beginning of the HIV/AIDS epidemic, they had the lowest seroconversion rate, that is infection rate. And those that didn't get on board until much later or never got on board had terrible outbreaks. And we're actually seeing it in the United States again, in areas where drug use has been increasing, and there these conservative communities that are anti-syringe exchange. You have outbreaks of Hep C and HIV, and just recently in some of those very conservative communities, the governors have been taking action, emergency action, because they see an epidemic happening. So it's terrible that unfortunately epidemics are necessary to drive political change. So let's move on.
Dr. Tatarsky.
Yes.
There's just a request for one more question.
Okay.
Just one quick question.
Thank
Sure.
you very much. Dr. Tatarsky, I strongly subscribe to your model, harm reduction model. And of course, everybody here believes that it's a global problem, really. I thought it is a behavioral therapy. Behavioral. Okay. I have
Is
seen.
that a question? Is my work behavioral? My work
Is it
behavioral?
a behavioral model?
Well, you'll hear.
Behavioral therapy, behavior modification
Well,
model.
We'll get into that in detail. I think of my work as integrative,
Yes.
because I think if we
Multimodal.
think about the drug use as happening in a whole person in their social environment, drug set and setting,
Yes. Okay.
we need to be thinking about blending interventions that address the body, the mind, and the social
Yes, yes,
circumstances.
yes, I
So I
understand.
think we need to be thinking much more than just behavioral, although that's clearly a central part of it.
Okay. So you were asking for changes. I would suggest my philosophy is more on the preventive aspects, and I would like to look into the cultural aspects, because I have made small-scale studies of multicultural, cases of drug abuse. And I looked into the personality type of those taking up drugs. They use drugs as an emotional crutch. That is the findings of my small-scale and very humble studies. We work 24 hours. I'm a nurse. My bachelor's degree is in pediatric nursing, my master's degree in psychiatric nursing. I made further studies, so I have a group in the Philippines, psychiatric nurses specialists, and we are registered in the securities and exhumation. We have a daycare center, but we work on the preventive aspects, child level, adult level, geriatric level, marital crisis cases. So we do crisis intervention, and of course, we don't go into rehabilitation of drug abuse. We try to prevent. We work on the families.
So it sounds like you're doing a lot of what you're going to hear me talking about already.
Well,
Great.
I have been listening intently, and I appreciate your very informative and enhancing lecture, sir. Thank you.
Thank you.